morning, everyone. Today we are really very glad and honored to have two distinguished guests from South Africa and the United States to be as a keynote speaker in our annual conference. And the first guest speaker, keynote speaker, will be Dr. Adri Koch. Dr. Adri Koch currently is the president of the International Society of Internal Medicine. She is a specialist physician in private practice in South Africa. Her diabetic clinic was established in 1996 with a team comprising of diabetic educators, ophthalmologists, group pediatric and diabetic practice. Today, approximately 8,000 patients have been treated in her clinics. Dr. Adri is also an external examiner for internal medicine at the University of Witwatersrand in Johannesburg, South Africa, and honorary lecturer from 2019. She is also the president of the Faculty of Consulting Physicians of South Africa and serves on the executive committee of the International Society of Internal Medicine. And since last year, she was elected as the president of the International Society of Internal Medicine. She was the chairperson of the organizing committee of the World Congress of Internal Medicine 2018, which was held in Cape Town, and very, very successful. More than 80 countries participated in that World Congress. Her research interests include very extensive fields, including intensive care, pulmonology, rheumatology, cardiovascular disease, infectious disease, and diabetics. She was the national principal investigator for several multinational trials with a focus on diabetes. And she did a lot of national and international speech in very important meetings. Today we are really very glad to have Dr. Koch come to pay Taiwan again. And actually she has been here 2 years ago, and we are really glad to have her to be here again. Please join me to welcome Dr. Koch.
Good morning, everybody, and as always, thank you very much for the very kind invitation. And you become friends rather than just colleagues, because you also honored us by coming to South Africa with your delegation last year, and I'm very glad that you enjoyed the visit to Cape Town. I think this topic of diabetes is such a crucial one for us, because it is an epidemic that has really been attacking us across the world. I just wanted to give my disclosures. The only reason this is like this is because in South Africa we don't have that many physicians, so we have to do lots of stuff. I think if we look at diabetes and how we understand diabetes, it's become very clear that cardiovascular disease is really the reason why our diabetic patients die. High sugar does not necessarily cause the problem. And if we look, I've just put up this slide to give the explanation of dilatation, hypertrophy, and in both cases, heart failure. Now, how does this affect us when we look at the diabetic patient? It's obesity, which is becoming an increasing scourge around the world. Type 2 diabetes, which you know is escalating. Hypertension and dyslipidemia. So these four attack the heart and the cardiovascular system. And we've only really in recent years started to understand a little bit better how these different areas intersect on the diabetic patient. We know that our understanding of diabetes has improved significantly in the last few years. And clinically, where we previously only understood a little bit about the pancreas, we understood about how the glucose production was affected, how glucose uptake was affected, glucose absorption. And then it became clear that there was a very important other organ involved in glucose control, and this is the kidney. And so the SGLT2 inhibitors came on the market more recently, and as these agents have been tested and we've seen their application, we understand much better how diabetes can be influenced from that point of view. But the other area that was interesting is how these agents, the SGLT2 inhibitors, affect the cardiovascular system. So it was originally developed as a diabetes treatment, and then we look at heart failure, and suddenly we found that these agents had a significant benefit in heart failure patients. So if we look at heart failure, this is just a summary really of the pathophysiology. We know that there's the natriuretic peptide system. On the one side, we have the sympathetic nervous system on the other side, the renin-angiotensin system, and these interact with one another to worsen heart failure. And the landmark trials that have really helped us to manage heart failure better over time has increased our understanding as to how we should apply the various medications. And this is just a summary of the major trials that have influenced our management. So at the moment, we sit with a stepwise management of heart failure, from where we initially started with the ACE inhibitors, angiotensin receptor blockers, and then as time went on, we understood more about the role of beta blockers, and then more recently, the role of sacubitril and valsartan, the neprilysin inhibitor, angiotensin receptor blocker combination. Some of these have improved mortality and given us a better outcome for patients. Others have only improved really the progression of heart failure. And then we have now more recently had the influence of the SGLT2 inhibitors. So what they found was, and I'll show you one or two of the studies, that because you are exchanging glucose at the kidney, you also lose salt. And of course, salt is one of the most important aspects of fluid retention in heart failure. And so the salt exchange also has a diuretic effect. And there seems to be a benefit of these SGLT2 inhibitors on the heart function, especially on the inflammatory response, and then also on the function of the heart in heart failure. At the same time now, we have agents that work on the beta cell. We treat insulin resistance, but in addition now, we lose glucose in the urine. I spoke a little bit about this 2 years ago when I was here, and since then we've had some newer trials give us even more insights. So these agents work independent of the pancreas, they're independent of insulin secretion, and so they have no interaction with the beta cell or the pancreas at all. You simply lose glucose in the urine. And of course, as I said, with the glucose loss, you have sodium loss. And this improves the diuretic effect that these agents have. So when we look at previous trials in diabetes, the only really intensive intervention trial was the STENO2 study. This is already old, but again, the 7 to 10 years follow-up of the study showed that the initial management of these patients, if it was done well with intensive therapy, looking not just at sugar control but also lipids, treating the blood pressure, stopping people smoking and using aspirin, made a difference even years down the line. You can see that the 13-year follow-up showed us that that initial management made a difference to the patient in the long run. And I think this is the story with diabetes. You have to treat the patient early to see the benefit. And what they showed was that with intensive therapy, which meant that they really tried to get the glucose to good control, they addressed the lipids, they treated the blood pressure, they treated microalbuminuria, they gave aspirin unless it was contraindicated, and they actively stopped people smoking. They helped them to exercise and they helped them to lose weight. It made that kind of difference as far as the outcome is concerned. And even apart from cardiovascular disease, it also had benefit for the microvascular disease such as neuropathy and retinopathy. So following that, with the SGLT2 inhibitors available to us, the major ones that have been studied is empagliflozin, DAPA, and canagliflozin. And I'm not going to go through each of these. It's just to show you some of the differences in these agents, because there are differences. And some of the benefits that we see, we thought, could it be a class effect, or are there other reasons why this has happened? And I think the studies have shown us that in different populations, these agents work very, very well and very effectively. The body weight reduction in the initial studies seemed to be slight, not massive, but there was a weight benefit. So different to some of our older treatments for diabetes, this weight benefit was quite significant, and clinically what we see is that the weight benefit is even more than what was seen in the trials. And interesting enough, I'll show you a slide a bit later, that the weight benefit was not fluid loss, it was actually fat loss. So they did DEXA body scans to show that the weight loss was associated with fat loss, not just water, because we thought maybe it's just a diuretic effect, and that's why these agents were effective. The important thing about this is that at the same time as treating the sugar, you improve now the vascular disease outcome of these patients without adding to the problem by causing weight gain, which you know has been a problem with the sulfonylureas and specifically with insulin. I've just summarized the cardiovascular outcome studies for you because it is important when we read these trials to remember that different populations were studied by the different agents. So the sickest group was the EMPA-REG study, which was the first to be given evidence in our publications. And they showed that patients had significant benefit if they had severe vascular arteriosclerosis and arteriosclerosis-related vascular disease. And there was a mortality benefit apart from a morbidity benefit in these patients. Canagliflozin was studied in the CANVAS program. That was the second group. So these were patients with multiple cardiovascular risk factors, but they were not as sick as the first trial, which was the EMPA-REG study. And then the third trial that came to publication was the DECLARE TIMI 58 using dapagliflozin, and they showed that in patients where there was just some risk factors in the type 2 diabetic, that even in the less sick patient, there was significant benefit in these when this agent was used as part of the treatment. And unexpectedly, there was the benefit in heart failure management with these agents. When they then followed up and looked at the outcomes in the cardiovascular trials, they noticed that there was also a renal benefit. So this was now the third part of the sort of triad of how these agents benefit the patient. So there was the sugar benefit, the diabetic control, there was the improved cardiovascular outcome, and then unexpectedly there was an improved renal outcome. So the patients actually were protected from a kidney progression point of view with nephropathy. And so they showed that with all of the agents there was a benefit over time to protect the kidneys. So when it works on the kidney, you'd think that maybe they would be a problem in kidney failure. But what they found was that these agents actually protected the kidneys. So it reduced progression of kidney failure, and it also protected the kidneys in the long run. So different to what we thought would happen. We know that there's a risk of ketoacidosis with these agents because there's a ketosis that develops, which is not necessarily ketoacidosis, and that's important to check. So if you have ketones produced, this seems to have a beneficial effect on the heart. And it's only that some patients unmasked a late onset autoimmune diabetes of adulthood, and those will have to be monitored for. There was a question about amputations in the Canvas trial. This has not been shown in the other outcome studies, and it was only seen in small digits in people with pre-existing vascular disease of the small blood vessels. And so in subsequent trials, the amputation was not seen as a risk for these agents. There was also a question whether they could worsen fractures, and again, that was not demonstrated. And we have more than about 30,000 patients now having been studied in these different trials. It's also important that different levels of renal function was benefited. So it wasn't just the mild renal failure, it was also patients with advanced renal failure where there was a benefit seen. So that we go to an EGFR of 30 moles would still be indicated to use these agents. Below 30 we don't have data yet. I just showed the ketoacidosis. So I think the cardiorenal benefits of these agents have now become clear. So it's not just the patient with atherosclerotic cardiovascular disease, but also those with renal failure. And so the renal failure aspect of heart disease is extremely important to consider when we look at the management with these patients. So we have both primary prevention as well as secondary prevention, where there's people with existing disease where we want them to reduce the risk of vascular mortality. And so if you look at these risk reductions, very significant. Just with the renal composite, you can see there's a 42% improvement, 31% on heart failure, and the diagnosis of vascular complications such as heart failure, myocardial infarction, and stroke reduced by 14% total. So a 14% improvement in mortality outcome when you use an SGLT2 inhibitor as part of your treatment. So before this was published, the DAPA-HF study, the American Diabetes Association as well as the European Association for the Study of Diabetes actually changed their guideline, and they now have a separate category where they say if the patient is at risk of renal disease or heart failure or vascular disease, the SGLT2 inhibitors with the GLP-1 receptor agonists should be considered as your first line of treatment. And this is added to metformin. If there's none of those complications, you can look at the other possibilities as far as treatment is concerned. So your DPP-4 inhibitors, the pioglitazones, and then insulin. And I think it's become really important that we make this distinction as we better understand how these agents can influence the management of our patients. So the DAPA-HF study was presented at the European Society of Cardiology recently, and they looked at if you have a patient with or without diabetes. So for the first time now we say, okay, so this is for treatment of diabetes, but what about the patient who's not a diabetic? Would it still benefit them? And they wanted to look at standard of care, which is all the agents I showed you before, versus now using dapagliflozin 10 milligrams superimposed on standard of care. And they wanted to see what the outcome would be. And if you look at the management of these patients, you can see that they had very good management. They had very significant, they even had implanted defibrillators. They had support on the cardiac side. And various agents like the beta blockers, etc., were used in good numbers to be able to see. So it was a very well-treated group of patients. And in this group, you can see that from the hypertension, all the risk factors on the left-hand side, and some of them had significant renal impairment at the time when they were included in the study. And only 42% of these patients were actually diabetic at the time of diagnosis. And you can see that there were 4,700 patients in this particular trial. So what they showed was that for heart failure or death due to heart failure or an urgent heart failure visit, that there was a 26% improvement in outcome in these patients. Very well treated patients, and you can see that the curves diverge very early on. So even in the first 3 months, you already saw a benefit when you use these in patients with or without diabetes. And furthermore, they showed that if you look at cardiovascular death, there was an 18% risk reduction. So remember now, this was originally developed for diabetes. Now we're talking heart failure in patients with high risk and those with renal dysfunction. So it gave us even more information as to where these agents should be applied. And this has led to an adjustment in the heart failure recommendations from the European Association. I'm not sure if it's been incorporated in the American guidelines yet, but that these agents are now considered add-on therapy in patients with heart failure with or without diabetes. So I just thought to bring you some cases just to demonstrate when we now look at patients, how do we make a decision going forward? So this is a 66-year-old male, type 2 diabetic for 6 years. HbA1c completely uncontrolled, 10.4%. Blood pressure was good. LDL cholesterol not controlled. BMI of 32, which is sort of a usual BMI for South Africa. He was on an ACE inhibitor. He's on simvastatin, metformin, and diaglycide as far as his treatment was concerned. And so he was treated by a cardiologist before. And in South Africa, the cardiologists are not great treaters of diabetes. So we usually have an opportunity to see these patients and manage them accordingly. So this patient had ischemic heart disease, 3 stents before he was on aspirin. And so we adjusted his treatment to a high-intensity rosuvastatin. He was on good heart failure treatment. Pro-BNP was elevated, ejection fraction of 28%. So what could be our next option? And in this case, this is a typical type of patient where the SGLT2 inhibitor or a GLP-1 receptor agonist would be indicated. And specifically liraglutide or if available, semaglutide would be the agents of choice. The same benefit was not shown with the other GLP-1 receptor agonists. So that would be where this particular guideline would take us to manage this patient. And it brings us to the point where the old cardiovascular trials looking at safety and outcome just proves the point that if you have patients that have been diabetic for a long time, you can see that the Accord study, 10 years of treatment, 8 years, 12 years in the VADT trial. In the newly diagnosed patients, there was a benefit if you treated these patients early. And so the plea is now that early treatment will make the difference. So these agents should be used early on in our management, not delayed. Because if you look at the proliferation of disease, early changes lead on to more advanced changes and then more severe outcomes, and especially as far as cardiovascular disease is concerned. This is another case, 45-year-old man, ex-smoker, type 2 diabetic for 8 years. He was on metformin with basal insulin, BMI again of 32. Blood pressure was controlled on ACE, calcium channel blocker, His LDL was not quite at target, because we'd like the LDL to be at 1.8 at least. HbA1c was still not controlled, history of ischemic heart disease and previous stents. And again, so what should we do as far as treatment is concerned? So in his case, we can escalate with an injectable GLP-1, or we could add the oral SGLT2 inhibitor. So our whole focus has changed in managing these patients going forward. This is just the study I wanted to show you, where they looked at the composition of the body, so that the weight loss was actually associated with fat loss, not just fluid loss. And the same was seen if you look at patients' hematocrits, to show that this was not a dehydration, but actually a fat loss that caused the weight benefit with the SGLT2 inhibitors. And of course, we see the same also with the GLP-1 receptor agonists. It's not to say that you will get weight loss, but there's a weight benefit when you treat these patients. This is the final case, a 52-year-old lady, HbA1c of 9.4% when she came to us, BMI of 26, lots of risk factors, and quite a high dose of insulin with metformin at the time that she came to us. And what we showed is we added a DPP-4 inhibitor metformin combination, which is easily used in South Africa. She still initially required high insulin doses, and then again, both of these agents are insulin sparing. So you can reduce the amount of insulin you use, you have a weight benefit, and of course the cardiovascular protection that I've mentioned before. In the Swedish registries, they've shown that if you use a DPP-4 inhibitor, and in their case dapagliflozin combination, that the patients had a significant benefit from all-cause mortality compared with insulin. So where insulin was our first go-to to get the patient under control, we now have significant alternatives that we can use for these patients. And the same was shown again. This was just a 56% lower risk for all-cause mortality with DAPA, and the DPP-4 inhibitor, a 41% lower risk for all-cause mortality compared with insulin. So we have really made a significant inroad into how we manage these patients effectively. I wanted to just add the non-alcoholic fatty liver disease as another new target for our management of these patients. This is a very big problem associated with type 2 diabetes. And what we've seen is that there's again this type 2 diabetes cardiovascular disease intersect. It's not yet shown how this affects the kidneys, but it is important that this progression of disease from fatty infiltration of the liver to more advanced hepatosteatosis can go on to cirrhosis, and then again hepatocellular carcinoma has become a real risk for these patients. So if we look at this intersection again, we found that in some of the trials there's been significant benefit where metformin could possibly help with insulin resistance, but it's not recommended on the atherosclerosis recommendations. Pioglitazone, working on the PPAR gamma receptor, they've shown in patients where there's a biopsy-confirmed non-alcoholic steatosis that there was benefit, and these agents also reversed fibrosis. And then more recently, there's some studies that have shown us that the liraglutide, specifically working on the GLP-1 receptor agonists, have shown benefit, the LEAN study, but it's not yet recommended. And what I didn't have on this was the UPLIFT study from India, where they showed that the SGLT2 inhibitors similarly had improvement in treating NASH. Importantly, from that side, it's not yet part of the recommendations, but it shows us that there's a benefit to treat the lipids, and especially lipid metabolism, as much as we focus on diabetes and the glucose metabolism itself. I wanted to just, as a final slide, let you guys know about the World Congress in Cancun in 2020. where I know that we'll have various of our Taiwanese friends come. And I want to make an offer from the International Society of Internal Medicine to have a competition for the best young investigator to be sponsored by us to this Congress. So I saw some beautiful exhibition outside of the research that you have done. And so I'll leave it up to your committee to make a decision as to who would be a recipient of such a prize. So we will organize that through your society, and I trust that we will be able to welcome a young investigator to Cancun on behalf of the International Society. And with that, thank you very much.
Thank you, Dr. Talk. It was very comprehensive about diabetes and renal and cardiovascular aspiration. Okay.
关灯会不会比较好？不会，
Okay, everyone. Okay, cheese. One more. Okay, thank you, everyone.